Hello and welcome, everybody. We are super excited today to have Rose Mollitor from ATI Advisory. Rose, I was hoping you could kind of start us off with a quick introduction.
Sure. Hi, happy to be here. Happy to be chatting with you about one of my favorite topics. I'm Rose Mollitor. I'm a managing director at ATI. We're a small research and consulting company, kind of across the public-private sector. But me specifically, I focus on Medicare Advantage, and most recently spent a number of years with a large carrier, leading some of our product innovation and design work. Directly in the supplemental benefits space, and prior to that, spent over a decade in federal positions working on Medicare issues and Medicaid issues in various capacities. So thank
So,
you for having me.
and really the perfect experience to talk about what we're talking about today, which is supplemental benefits. For folks who are a little bit less familiar with the MA world and specifically the supplemental benefits world, can you talk a little bit about like what are table stakes for a plan when it comes to supplemental benefits and what are the other sort of interesting things that a plan offers in terms of supplemental benefits?
Yeah, I think that's a good place to start. Obviously, supplemental benefits is one of the big value adds that MA plans offer, and oftentimes why members leave fee for service. Some of the big ones that folks are probably used to hearing mentioned, dental, vision, hearing, really are those table stakes. There's a few other supplemental benefits that at this point has become pretty much universal. So if you think about the fitness benefit, Silver Sneakers is a company that folks have probably heard of, and the idea of your seniors going to the gym, getting some social time in while they're exercising. So those are really some of the table stakes. To sort of a slightly lower level, there's other benefits that are very common. So limited meals after members come out of a hospitalization or a discharged home from a SNF to kind of support their recovery. And then OTC allowances, so allowances that can be spent on things like vitamins, Band-Aids. I almost think of it as like a FSA for Medicare. A little bit narrower, is another very commonly offered benefit. More recently, and I'm going to date myself here, I'm losing track of how many years, there's been pretty significant expansion in terms of what plans can offer. And so you've started to hear a lot more starting in 2019, 2020, around some of these non-traditional supplemental benefits. So in some cases, it's an expansion of supplemental benefits that we've seen in the past. So rather than post-discharge meals, it's meals on a reoccurring basis for someone who is chronically ill to help them manage their diabetes. But then we've seen even greater expansion in the non-health related space with some new flexibilities granted to plans, particularly the SSBCI flexibility. And I don't want to throw too many acronyms at you, but I'm probably even gonna mix it up, right? It's a special supplemental benefits for the chronically ill, I think is the right. And some of the demonstrations that have existed, the value-based insurance design and plans have been offering things like non-medical transportation, right? Just to and from grocery stores. Plans have been offering flex cards that can be used on a whole host of things, whether it's groceries, it could be more OTC items, it could be, in some cases, transportation. We've seen over the years pet supplies, some a little bit further out, and then a lot of caregiving support and social isolation benefits. I'm sure there's others out there, but just to kind of give you a flavor of that.
Yeah, that makes sense as kind of sort of positioning us for what is kind of the menu of offerings. As a plan, the other piece of it I think that is interesting and maybe a little bit unintuitive for folks is how these benefits are financed. Could you give us just a kind of quick overview of that?
Yeah. So Medicare Advantage plans are paid with taxpayer dollars. It's paid, they get a PMPM from CMS. And so really the pool of funding that they have to spend on these extra services, as well as, I think this is important to mention, to spend on coverage or cost share subsidization beyond what traditional Medicare offers, is really based on them being able to submit bids to CMS and commit to covering everything that Medicare covers in line with any kind of coverage requirements, regulations, actuarial equivalents at less than a benchmark that CMS is estimating it would cost in fee for service with some adjustments. I won't go into all the formulas. So plans then get to keep a portion of that difference. And that's really the pool, the rebate dollars that they have for these extra services. And I think, an old boss of mine, when I first moved into the business, who's really instrumental in just sort of my transition and learning everything on the business side, would hammer in constantly. It is a finite pool of dollars. And so while plans and vendors and everyone in kind of the policy and thought leader space gets really excited about the possibility with these benefits, $5 that I spend on a grocery card, I can't spend on buying down a specialist cost share. So I think that's an important framing to keep in mind when we think about when, and I know we'll talk about this more, when and how plans make decisions on benefits, because it's that pool and it's used for all of the extra services, not just what we think of as those extra benefits.
Yeah. I think that's a really great insight and a interesting transition to my next question, which is, as if I'm a plan, how do I think about what kind of benefits these deliver? How do I navigate those trade-offs that you just described, where I'm saying, people are price sensitive. I can either decide to buy down this. It's all one pot of money. And
Yeah,
then as an extension to that question, and I apologize if I'm packing too much into this question, but
you
what does
might have
that
to
look like
remind me.
between a regular plan and a special needs plan?
Yeah. Okay. Um, So ideally, right, plans are leveraging all of the vast data analytics and expertise that they have in-house to help them make these decisions. I think it's important to remember that um, unlike traditional Medicare Advantage plans really function on the basis of recruiting beneficiaries to make the decision to actively enroll in these plans. So obviously marketing is a really big component of that. So anything that a Medicare Advantage plan is doing, they have to think through the impact that it has on the ability to attract and retain members, but then also the impact that it has on the financial bottom line, right? And there's nonprofits, there's for-profits, but at the end of the day, all of the plans need to be solvent. And so when they're thinking about where to allocate these rebate dollars, they are conducting a number of analyses looking at what is the cost of providing the extra benefit, what data do we have on whether or not there is a net positive ROI, and that could be in actual medical costs, but it could be in retention, right? Cost the plan less if they can retain their members than having to go out, recruit, bring on new members year over year. And plans are also looking at which benefits drive the most value for the populations that they feel capable of successfully managing. I think that's the other key piece. And it does sort of go into the SNP question that you asked. Carriers design plans around specific populations and demographics, and you can see different benefit structures, right, based on sort of target membership. You might think about a fairly healthy recently aged in individual. Plans maybe are more likely to design a package of a plan that has fewer supplemental benefits, bells and whistles, but has a broad network. So sometimes we see benefits on some plan structures that we don't see on others. And that's particularly important when you're talking about the SNPs. This is an evolving space. We've seen a lot of growth for a long time for dual eligible C-SNPs, dual eligible SNPs, so many acronyms. Those are MA plans where eligibility is limited to individuals who have Medicare and Medicaid coverage. We also have chronic condition SNPs. So members must be chronically ill, and that could be a number of conditions. It could be a set condition. Right now, most of those plans are targeted at diabetes and cardiovascular conditions, but there's the flexibility to offer targeted plans and other conditions as well. And then we have I-SNPs, institutional SNPs. So those are regulatorily defined targeted plans. Even in the non-SNP space, you do often have a portfolio of plans, and the benefits will look different depending on who's being targeted. But in the SNP space, these benefits are that much more important. You have oftentimes a lower income, right, population, so they've got a lot more medical needs, and they often, excuse me, have a lot of additional health-related social needs, right? So we talked about some of those non-traditional benefits. That's really where you see the greatest availability, penetration, highest dollar amounts, if you're talking about things like grocery cards, is really in the SNP space. And that's critical, both in terms of plans being able to support the membership, but really in terms of being able to attract and retain that membership. With the takeoff, especially over the last couple of years, in terms of C-SNPs, you're seeing similar trends there. There's a lot of overlap between those populations, but not entirely. And so that's, I would say, in 2025, in 2026, and we'll probably see this in 2027, as we've seen some of the tightening of the rebate dollars available for benefits, you're seeing even more of a greater shift to it's the targeted SNP plans that still have a lot of these benefits versus your non-SNP plans, just because of the population and what drives, their enrollment decisions.
When I think about, a Medicare Advantage plan, I was reading a health affairs article yesterday about MA enrollment in for dialysis providers, right? And I think about a all of the unique needs that a dialysis patient has in terms of comorbidities and non-emergent medical transport and stuff like that. And so it seems to me like, a lot of insurance is the game of an insurance is trying to make your risk pool as broad as possible. But what these condition specific SNPs do is allow you to really tailor a package that brings in people who have a set of needs, and the supplemental benefits allow you to kind of address some of these social determinants. Am I thinking about that correctly?
I think I think you are. I think that is definitely one of the tools that's out there. I think what is interesting to watch and remains to be seen is sort of over the next couple of years where that real customization and specification goes. And you actually even see in the proposed rule that came out with the RFI, one of the questions, I know on the SNP RFI, a lot of the questions were about dual eligible enrollment in C-SNPs, but at the very end of it, there were some questions around what CMS could do from a policy perspective to encourage more C-SNPs that were focused on substance use disorder and behavioral health. Because to your point, there have been ESRD C-SNPs in the past, and you really could design some pretty robust care packages around these specific high need conditions. What I think becomes challenging, and this gets to kind of the broader policy conversation and how you align incentives for insurers and make sure that, reimbursement aligns with costs, aligns with proper incentives, and both for nonprofit and for-profit, is just that it can be very challenging if you don't have the mixed risk pool. You have to be very, very certain that you're going to be able to manage that population and their needs based on the revenue that you think you're bringing in. So I personally, from the policy nerd side of things, would love to see more experimentation in the C-SNP space around what you can do when you really design a care management model around a particular condition. But I also know from sitting on the plan side that it can be really, really challenging. And I think that that's why to date, you don't see as many of those. And I think that was one of actually the fun things about the value-based insurance design is you sort of got to do these mini C-SNPs that were maybe more narrowly focused within a broader plan to start to build your evidence pool. But I do know that VBID, as it expanded, kind of shifted more to looking at income level, and obviously is no longer an option.
That's actually you're doing my job for me today, but that's a great transition into from like the regulatory perspective. So I know VBID phasing out, there's some new regulations going into this year. Could you give us an overview or some flavor on what is changing from a regulatory perspective?
Yeah, I think the top line message in the benefit space from a regulatory perspective is we sort of rode the innovation, expansion, creativity wave for a few years, and we are crashing into kind of oversight, justification, and proof being the theme. And so that's in a few different places. So over the last couple of years, there's been a lot of tightening around marketing rules for plans. And that's both on kind of the broker, compensation front, but also really around how plans can talk about their benefits. I think for a long time, plans had the flexibility to kind of err on the side of list everything out that you could possibly get. And in the last year or so, that I was on the plan side, we spent a lot of time with our marketing counterparts around this idea that you have to be very, very careful in what benefits you talk about, and they really need to be universally available to be able to substantially market on them. There's a lot of concern around members enrolling in plans thinking they have access to a benefit that they really don't. Plans saw the addition of a lot of disclaimers. So back when we still had VBID and SSBCI, I still have a little bit of PTSD working with some of my friends on all of the disclaimers that needed to go on marketing materials. And if one was being used for a benefit that could be VBID or SSBCI, it needed both. So there's been a lot there. And I think it's for member protection, especially, right, we're kind of coming out of AAP. I don't know if you saw the John Oliver special on Medicare Advantage marketing, but the commercial was fantastic. But that's sort of, to illustrate, there's this period of time where there's all these TV commercials about what MA plans can do for you. So it's really trying to put more restrictions on that, make it more accurate, ensure that members aren't being misled. And at the same time, there's been a lot of new reporting requirements introduced. So plans report huge amounts of data to CMS to begin with, primarily, claims, diagnoses, all of that. And a lot of this information goes into the bid buildup to justify the costs that plans are charging for providing this coverage. The supplemental benefits, however, have historically not been included in a lot of the reporting requirements in terms of utilization and cost. And so really 2025, this year, and as a data nerd, I'm excited to get a hold of it at some point, is kind of the first year that there's been a heavy focus and reporting requirements are in place for the whole year around having to report on availability of benefits, whether or not they're available to all members, if they're targeted, who they're targeted at, what's the actual acquisition cost that plans have for those benefits, what's the uptake and utilization. Some of your listeners, and I'm sure you've been tracking this, right, have been hearing concern around utilization of these supplemental benefits. Are they put out as marketing devices and then too complicated for members to use? Members don't know about them, right? So the marketing and the reporting requirements together really signal CMS saying, we want to know more about what you're doing. We want to know that there is a value out there. And actually, I missed one that I should mention for the non-primarily health related benefits. There's also new requirements that plans need to essentially provide justification, right? Literature reviews, internal analyses, showing that these benefits do have an impact on health outcomes. So kind of, taken together, it's really, it's not that you can't do these things, but you need to show the value to the member, the value to CMS, that they are impacting health. And I would say on the plan side, it's important because as the margins are tightening, as we're in a different place with utilization, plans also need that data to actually calculate an ROI. It's something that we do sometimes for vendors and plans, and it's really, really challenging. And I can say, when I sat on the plan side, unlike some of the medical data, I would say the data that sometimes came in on supplemental benefits was not to the level that you could do the types of analyses you might always want to do from an ROI perspective. So I think that even though it's burdensome, ultimately getting the data cleaned up on the supplemental benefit side will be helpful to the plans as well. Sorry, that was a long tangent. I think I
No, that
went.
love a long tangent. So that connecting that back to what you were talking about earlier, and this we went through a creative period, and now you have to show your work a little bit more. It feels like things like intuitively to me feels like paying for pet food and like having a as I had someone with two parents who have a pet that brings like a lot of value to them. Like I get it, but also that might be much harder to show your work on than something like, non-emergent medical transport or something like that.
I think that's right. And I think this in some ways goes to, not to go too kind of existential, but like, what is the role of a health insurance provider, right?
Yeah.
And it's similar to the comment about what do you spend your $5 on? Because in a bubble, all of these things may have value or have value to someone. But is it the role of the health insurer to provide that, or is there a different social program that should, or is there a different place that should come from? So it's that combined with, to your point, um, what's the biggest bang for your buck? Where can you show your work, both from a plan bottom line and also from an oversight perspective? I think the debate around whether or not supplemental benefits need to be used in order to be valuable is one that's really interesting to me. And I think about this in the dental space. I think that's been a big focus, right? But in general, and we saw the new requirement right around mid-year benefit utilization. And so for those not familiar, starting this year, plans were supposed to have had to send out notifications to members who hadn't used their supplemental benefits halfway through the year to remind them of the availability. That was first sort of delayed, and then in this most recent proposed rule, they are proposing to remove that for a number of reasons. One of the things they mentioned is that they're actually seeing higher utilization than maybe they thought before. So I'm interested if that's the 2025 data, but there wasn't a lot of detail in there. But putting that aside, and I've had this conversation with a lot of folks kind of who do work in the supplemental benefit space, that it's really important members can access those benefits and that it's easy. There's not artificial barriers, that if a plan says they offer dental coverage, there is dental coverage and it's there if they want it. And there's definitely work that can be done there. On the flip side, not all members are the same. And when plans buy and price these benefits, expected utilization of these benefits is a key component. And so if CMS creates regulations to drive plans to ensure that any supplemental benefit has high utilization, whether it's 100% or whatever that max should be, that will have the impact of significantly reducing the types of supplemental benefits that might be available on a given plan. And so the unintended consequences, someone who, doesn't need a hearing aid may no longer have the option to use an OTC allowance on something else because vision has gone to 100% and they can only afford dental, vision, hearing, and that's table stakes. So striking that right balance between it's not necessarily bad if a benefit's not used, as long as the benefit is there if a member wants to use it versus artificially kind of driving utilization just because it's there.
Yeah. That's an interesting nuance. And, I think about the person, like no one likes going to the dentist, but it is nice to know that you have dental insurance. And there is some sort of psychological security. And so how do you regulate that is like a very challenging question for CMS because yeah, there's just like a trade-off there. We only have 5 minutes left, and I want to get a little bit to trends that you're seeing going into
Yeah.
2026. Could you give us a flavor of what you're seeing and hearing on looking forward?
Yeah. I'm hearing, you know, sort of an acceleration, a continuation of some of the trends that we saw for 2025 and 2026, which is um, kind of simplification or rather standardization where it's appropriate to help with the ability to communicate about benefits that plans have, but also kind of further customization and specification and a tightening or targeting of the benefits and the product types to the members that the plan is trying to serve. So I think we will continue to see this shift. We saw a retraction just from a plan availability, right? We saw a retraction of non-SNP plans and continued growth, really exponential growth in the C-SNPs, but continued growth with the D-SNPs. And so from that perspective on net, we sort of saw both in plan availability and supplemental benefits availability, um, like status quo, but really a shift between the two sides of the house. And in 2026, and we're for those on the plan side, going into bid season for 2027, which in some ways is where my mind is right now. I think we'll continue to see that. I do think we will see that continued honing in on which of the non-traditional or innovative benefits are driving value. And so I suspect, to your point on pet care rate, less of that, more of your maintaining the grocery card, the non-medical transportation for the plans where it's really valuable, and the continued decline. I'm looking for my facts and figures, but I think we saw right decline in these benefits on the non-SNP side. I think we'll continue to see that. I also think that just when you have margin pressure, financial pressure, utilization pressure, again, you do see plans kind of going back to basics. And I think we'll continue to see that theme coming through in 2027 and less sort of new benefits popping up. One place where we did see on the SNP side a little bit of an increase that I think we'll probably continue to see is that caregiver support, in-home support, because for certain populations, that's really critical and can have a really big impact on medical cost and quality outcome. And so I know we don't have time to talk about it. We didn't talk about it, but this idea of supplemental benefits when they're a marketing tool and when they're a care management tool and kind of the difference there. But I think that's one place where you may see some continued expansion as carriers think about how to manage those populations with those really high kind of needs in terms of in-home care.
That is such a great place for us to put a pin in it and pick it up in a couple weeks when we get to have you back. But until then, where can people find you if they want to get in touch, if they want to learn more? What's the best way for them to find you?
Well, I have a very simple email address. It's rose at atiadvisory.com. And always happy to just chat about what we're seeing or talk more tactically. It's a fun place to be. And it's been fun to be thinking about these issues, right, from the policy side and the business side.
And Rose and ATI Advisory recently put out a really great 2026 supplemental benefits overview. I'll share that in the show notes. Rose, thank you so much. We really appreciate your time, and I hope you have
Thank
a
you.
great
Thank
rest
you
of
for having
your,
me.
yeah. All right, bye.
Bye.